everyone, I'm Dr. Swati, one of the mentors in Study Medic. So here again, we are with our new YouTube series related to MRCOG Part 3. So in this series, we will be taking up very important exam tested tasks, which are super important for you for exam preparation. So one by one, module wise, we'll keep on taking up the most important stations. We'll be discussing them as if it is a SPT, then we will be taking up the role player and examiner. This task related to management of labor is basically a structured discussion about the second stage cesarean section. So I'll be the candidate and my examiner will be Soumya ma'am. So we will be performing the station in the exact manner, the way we do in examination, 2 minutes reading time and 10 minutes performing time. And then I will be evaluated by my examiner regarding what I did good and what I did bad. Domain wise, ma'am would be telling me. So let's start. So I'm putting the timer of 2 minutes. And once my reading time finishes, I'll be performing the task. So yes, my 2 minutes reading time has started. Let me have the station. So this is structural discussion.
Swati, you can start, I think.
Yeah. Hello, I'm Swati, one of the exam candidates, and I have read the scenario and I'm ready for the structured discussion.
Okay. Swati, you can go to the first slide because the candidates won't see the exam questions, no? Okay, fine.
Yeah.
Yes, can you please summarize the case for me?
Yeah, so this case is basically, I would like to summarize in an S-bar format. So the situation which I've been presented with is that of a patient, Miss McKenna Donald, who is 36 years old, and she is currently in the second stage of labor. And I see that she has been pushing for the last 3 hours, which is now quite prolonged, and she also has an epidural in place. On the background, she is a low-risk pregnancy until now, and her CTG seems to show the signs of distress, decelerations, and she is fully dilated, and also there is significant caput and molding on the background, which I observe. As such, on assessment, I find that she is a low-risk pregnancy. On per abdominal examination, her contractions are good. On per vaginal examination, the head is, the presenting part is 1 centimeter above the spines. Head is in left occipito-anterior position, and there is very significant caput and molding. And also the CTG is showing signs of significant fetal distress. So my recommendation will be the further immediate obstetric review so as to consider assisted delivery. And this assisted delivery may be in the form of instrumental delivery, but here, if we see the criteria, I don't think she is fit for instrumental delivery. So ideally, my recommendation, according to all the assessment, should be second stage cesarean section for fetal as well as maternal well-being.
Okay. So while considering the decision for the delivery, so what additional information you want to know about this patient?
All right. So regarding further information gathering, first I would like to know about her current pregnancy. What was her routine antenatal, any antenatal complications which she had? As such, it is given to us that she has been a low-risk pregnancy, but further additional investigations, her notes I would like to review. I would like to ensure that what is her gestational age, what were her scan and blood reports, and regarding her other obstetric history, means previous pregnancies, what were the outcomes, what was the baby weight, mode of delivery, history of any complications she faced in her previous pregnancies or deliveries. Then now her medical history, any chronic conditions she is having which might modify her management, any surgical history, any medications she is on, any allergies, because we might need to use quite a lot of medication, so we will rule out any allergies. And then her routine, whether she is a smoker, alcoholic, and what is her support system, who is her birth companion. And regarding this labor, since how long she has been in the second stage of labor, how was her first stage of labor, the duration as well as the progress in first stage of labor, whether any ARM was carried out or whether she had spontaneous rupture of membranes, and since how long she has ruptured her membranes, any interventions which have been done in the first stage of labor. As we can see in the second stage of labor, she is on oxytocin drip. So since how long she is on oxytocin drip, and her analgesia. Analgesia is very important to ensure that she is comfortable. And Yes, so this is the further information which I would like to take.
Okay, so as you know, she was a low risk, so primigravida, and that's a term gestation. So first stage of labor was absolutely fine, but when she was 8 centimeters dilated, the contractions were less, so that's why she was started on syntocinon. Anyways, the midwife is concerned because she's on epidural and pushing like probably fully dilated for 3 hours. Considering all these examination findings, so how would you proceed managing this patient?
Right. So as we see that now she is in second stage arrest, and now she definitely needs intervention to facilitate her delivery, since caput and molding are also significant and fetal distress is also significant, and the time duration has already elapsed. So already we can label her that she has gone into second stage arrest. So now the two options which remain with us to facilitate the delivery are either instrumental delivery or second stage cesarean section. But since for instrumental delivery, criteria should be satisfied, which here it is not. Caput is also very significant, and the presenting part, since it is 1 centimeter above the spine, so that's why second stage cesarean section would be the definitive management which I would like to suggest for this patient after a thorough obstetric senior review. So now in second stage cesarean section, when it has been decided, we will inform our consultant. When the decision has been taken, we need to inform our team, our whole team. We need to alert the anesthetist. We need to alert the pediatrician, and that is neonatologist. And this syntocinon, which she is currently on, we need to stop this syntocinon drip. We need to inform all the operating theater staff, our midwives, senior midwives, and then we will shift the patient to operating theater after informing her and her attendants also. We need to take a proper consent, and then as soon as she is shifted to OT, it is necessary that prior to opening her up, we need to perform a vaginal examination again and take some measures. WHO surgical safety checklist we need to fulfill. And yes, we need to alert our staff also, because we might be needing help in second stage of labor to push the head from down below. So we need to arrange a senior midwife with us also. And then pre-procedure, along with pervaginal examination, we need to check the fetal heart rate once again. And then we need to make everything for disimpaction of the fetal head ready. If we are going to do it manually, then we need to have a staff with us, or somewhere snorkel or fetal pillows are also used. So we might, if it is available with us, we need to get it ready. And then we will go on to apply Joel Cohen's incision, blunt dissection, in which we generally favor blunt dissection. Then our uterine incision specifically should be high up, and we will carefully separate the bladder flap because there are very high chances of injury to the bladder also in this case. So very carefully we need to dissect the bladder, and introducing our hand below the fetal head would be quite difficult in this case, so that if possible, we will do it very carefully. If we can, if our hand can reach below the fetal head, then it would be easy to lift up the head and extract. Otherwise, then we will extract the head by flexion. Otherwise, we'll ask an assistant to push the head from down below after the patient adopts a frog leg position. And while the operating surgeon will apply upward traction on the baby. And by flexion, lateral flexion, we will deliver the fetal head. The main concerns which we might face is not only fetal trauma, but also maternal trauma as well. Trauma to the lower uterine segment, which might extend laterally to the broad ligament. Also, the urinary bladder might be injured. So these are the challenges which might face. Sometimes if we are not able to deliver the baby through this method, then we might go for reverse breech extraction method, in which we grasp one or both fetal feet, which will be present at the fundus of the uterus, and then apply steady traction in the downward direction. So then we can get the buttocks, and following which we can flex the spine and extract the baby. So this will provide more space to the fetal head. But again, in this also, baby might suffer fractures, and there might be injury to the uterus as well. Then third method, which we can go for, is Patvardhan extraction method, in which both the hands and the trunk are delivered first, followed by breech, and then we lift the fetal head out of the pelvis. So this is the third method which we can extract. All these are manual methods. Then in any of these methods, we might need to extend the uterine incision. We might need to extend it to a T-shaped manner or a J-shaped manner. And if any of these is, we are not able to deliver the baby, then we might use a C snorkel or a fetal pillow. So ideally these things should be available in our labor unit. Then we need, after delivery, we need to carefully explore whatever injuries we have caused, whether there is any bladder injury or whether there might be a lot of blood loss. So we need to secure hemostasis perfectly and then close the abdomen. And then we need to follow specific post-op care instructions also in this case, like we need to monitor the vital signs by Meo's chart. We need to check the incision site for bleeding, signs of infection. We need to give her proper antibiotics. We need to shift her for a proper monitoring. We might need to assess lochia, adequate pain relief, analgesics, antibiotics, proper post-operative care we need to give her along with the IV fluids management and administer antibiotics according to protocol. And we might need to put her on oxytocin infusion for a prolonged period to ensure that the uterus is contracted, because she might suffer from PPH either immediately or sometime later. So we might need to be vigilant about that. Then afterwards, we will follow enhanced recovery plan. That is, we will encourage early ambulation if everything is going on well within 6 to 12 hours. And also we might need to give her adequate thromboprophylaxis, because the second stage cesarean section is quite risky and may predispose her to thromboembolism. So like this, we will follow. Also, we will encourage breastfeeding and adequate infant care, wound care. We will ensure adequate emotional support, and we will educate the patient regarding what happened with her. And in future pregnancy, we will document her that in her notes, so that in future pregnancy, the consultant can be well aware that she suffered all this in the previous pregnancy.
Any specific clinical governance points you want to mention?
Yeah, in clinical governance points, first of all, adequate documentation is very, very necessary, because surgical notes would be the key index as to what happened with her. And in post-op care, debriefing the patient as well as the relatives, as well as our staff members, so that we can strengthen the system of how to deal with the second stage cesarean sections. Debriefing team, we should carefully adhere to the guidelines. We should regularly audit, and in case if we find any flaw, we should try to work upon it. Then duty of candor is very important, as to we will explain to the patient what all happened, what was the course of labor and delivery, and what was carried out. And then comes the DATIX, that is incident reporting, which is very, very important, as to so that we can include the detailed information about the incident and use the incident report to potentially modify our areas of system for a better care.
Okay, so I think you overshot in 1 minute. I didn't want to stop you. So I think, okay, station well done. I really like the fact of SBAR, but probably you need not tell situation background assessment recommendation. The moment you start speaking, we would know. And what I really liked was the history about the first stage and the second stage. And as well, shifting to the OT was fantastic. But I just want to confirm, did you mention neonatologist? Because I didn't.
Yes.
You mentioned.
Pediatrician, okay. Neonatologist.
Fine, fantastic. With the methods, probably if you could signpost from before, push, pull, and then, Pativardhans and say snorkels. Actually, the fetal pillow, due to the conflict of interest, they have removed that, but that's still okay. But if you mentioned later on, but in the beginning only, if you mentioned the push, pull, and all that, that's fine. And probably you need to cut short your history taking, otherwise you will overshoot the time. The post-op, you can always make sure to cover as clinical and clinical governance, so automatically you'll be covering. Otherwise, I think it's a fantastic station. I really like the fact, because you mentioned, because it's -1, you don't want to apply the instrument, and I think that's sufficient. Well done. Thank you.
Thanks a lot, ma'am, for the feedback. And as we can see that in SBAR summary, we have to tell about the situation of the patient, the background in brief, whatever the important points. If we keep on speaking and speaking, we might overshoot the time, as I did in this station. So our history needs to be very brief and very specific. And then our management needs to first outline all the methods which we will apply. If suppose we keep on elaborating, and sometimes we might miss some important things because of lack of time. So it is very important to tell all the prerequisites, including consent, surgical safety checklist. Also, the fetal heart parvaginal examination needs to be done before performing the cesarean section. Then the push method, pull method, Patvardhan's method, and the C snorkel. These are the main methods which we employ to disengage the fetal head. Then post-op care, including baby care and emotional support, is very necessary. And also follow-up appointment needs to be covered. And then comes the VTE prophylaxis, and then the clinical governance points. All these, which clinical governance points will include the documentation, debriefing the team, as well as the patient with duty of candor and DATEX. These are the important clinical governance points. So this is the domain-wise marking, which you can refer to. And communication with colleagues will not only involve your communication with the examiner, which should be very clear, confident, very crisp, not including the unnecessary details, as well as MDT needs to be taken care of in each and every station. So pediatrician, anesthetist, the staff, everyone needs to be involved in all such type of critical cases. And then the information gathering. So these are the key learning points, and like this, you will be marked in each and every domain, whether if you are clear pass or borderline or fail, following which you will be getting a global marking, through which you will get to either pass or fail the station. So these are the theory things which are related to the second stage cesarean section. There are many important topics in the management of labor module. Not only second stage cesarean section, you need to be very thorough with the management of PPH, especially the flowcharts and algorithms. And then you should be very thorough with cord prolapse, situations like shoulder dystocia, maternal collapse. All these are very important stations for which you should prepare as a structured discussion in the management of labor. So hope it was helpful. Thanks a lot and all the best for your examinations. Thank you.